Tonight we were very, very, very fortunate to have Dr. Jaffe, our one and only, come over here and just kind of have a conversation with us about himself, his journey over here, and our path.
Thoughts on podiatry.
Yeah.
I don't know if I deserve 3 varies. I think one would do.
I just really mean it.
There you go.
Alrighty.
So like Maya said, Dr. Jaffe, he's a professor here. He's also the associate dean for clerkship and residency placement. So for the P1s, you'll be seeing a lot more of him next year. Super helpful with all of that. So we'll just go ahead and get started, and I'll just have you introduce yourself, and then we'll go into the Q&A. So just tell us where you went to school.
Yeah, sure. So
podiatry and all that.
Yeah, absolutely. So again, Leland Jaffe. I'm an alumnus of Scholl, graduated in 2008. Most of my clerkships were in the Midwest. My family is all Midwest, although my roots are all on the East Coast. My parents actually grew up in Coney Island, Brooklyn, and Long Island. So all my family's from the East Coast, but we migrated to the Midwest in the late 70s, and that's where I was born. So after I graduated in 2008, after I graduated, I went on to do my residency in Chicago. So my residency was St. Joseph Hospital, which is modern day Ascension St. Joe. When I was there, it was Resurrection, but it's undergone a few iterations since that time. And then my first year was actually spent at a VA hospital. After I graduated, and in 2011, there was actually very few sponsored fellowships. So not many of my peers went on a fellowship at that time. If you were really going into something that was like a niche, or if you felt like you needed more training, that's probably why most did a fellowship, but very few of my peers went on to do fellowships at that time. It really just didn't exist. There were fellowships, but there were very, very few. So when I graduated, I went into practice in St. Louis. I was in a small practice that was it was in Chesterfield, Missouri, which is like 20 miles west of the Mississippi River. But we had 3 office locations. I also worked at SSM St. Mary's, which is SSM is like a big medical system in St. Louis. It's part of the St. Louis University, but it was a great hospital to work at because we had residents from the podiatry residency program scrub in with me at that hospital. So it was kind of a weird experience. It was an immediate role reversal. You graduate residency one day, and then the following week you have residents with you, which was kind of odd. So that was an interesting experience, and really my first taste being in an educational role, I guess. And then my third location was in Edwardsville, Illinois, so Southern Illinois University, and that's where I worked in a wound care center. That was really my first taste of wound care. Most think I did a lot in residency. I really didn't do a whole lot of wound care. We had a wound care center, but it was really, really rudimentary at best. We didn't have a lot of resources, and it was more of a glorified office within a hospital where we saw patients that had wounds. It was pretty much the extent of it. So I was in St. Louis for about 4.5 years, and then in 2015, that's when I moved back to Chicago, joined the faculty, and I have been here since. So I don't know if I unpacked all of your questions.
That was good.
Yeah.
You want to tell us a little bit about how you started, like what piqued your interest into podiatry, and why did you want to do this versus like any other
absolutely.
professional?
So I realized really early on I'm not good at English and writing. Which was odd because I can go on a tangent for a while. We got an hour.
Yeah. We got time.
So no, I actually took the GRE a few years ago because I was planning on doing a PhD program also at the university here. Has anyone taken the GRE? So GRE is very math and then English based, and I tested way higher on my writing than my math, which was like my crowning achievement in my educational journey. With that essay, that was like the most proud thing I ever have had in my educational experience. So that was fun. And I didn't end up using it for anything. So I digress a little bit. But again, I was kind of the science and math person in college. So it was kind of the natural pathway. I studied biology and chemistry in college. Most people may or may not know my dad was a podiatrist. And my sister works in ER, So, she's an ER physician. My cousin is a neuroradiologist. So radiology was kind of on the radar too. So these were kind of some of the specialties that I was exposed to, I guess, as I was kind of contemplating medicine as a pathway, I suppose. But there wasn't a whole lot of pre-podiatry clubs on campus, but there was a good sports medicine department, and especially with the teams at University of Illinois, which is where I did my undergrad in Champaign-Urbana. Shout out. So I was kind of into the sports medicine part of it as well too. So that's where I sort of went down my dad's path, I suppose. And when I found out that surgery was involved, and I got to observe him in clinic, and I got to work with him because he was actually one of the attendings for the what's now the modern day SSM DePaul Residency in St. Louis. That's where I kind of went further down that pathway and found out that this is sort of the branch of medicine that I was interested in. So that's how I really found my way into that. So I thought I was going to be much more into like sports medicine. And I did have that proverbial like practice where we treated everything from infants to geriatrics. And so we did have every type of patient, including a lot of athletes. But in my first few years of practice, I kind of found myself gravitating more towards enjoying being on call, being on hospital rounds, being in that more interdisciplinary type role in the hospital setting as opposed to treating my athletes. So my practice, it was more of an organic evolution from, and fortunately that's the benefit of being in a small practice is you have a little bit more autonomy, right? If you're in a big group or a hospital, you're an employee and they're really telling you more so like this is what you're assigned to do. In a practice of just a couple, you really have the autonomy to curate your schedule how that best fits what you're looking for, right? So I kind of found myself filling my week more with being on call, working in when I finished in St. Louis, I was on 2 different wound care panels, so that was a large majority of my week. I subletted space from a hospital-based practice that had a rheumatologist and an endocrinologist, which again was a good referral source for a lot of these wounds as well too. So it was sort of an organic evolution from sports medicine to wound care, hospital-based type practice, which is a little bit more of what I treat nowadays.
Awesome. Thank you.
Yeah.
So, given that your dad was a podiatrist, did you ever feel pressured to become one, or was it kind of like an open conversation at home?
No pressure at all. It was more just, this is an opportunity if you're interested in it. You can come to clinic, observe, participate, shadow. I was able to go to the hospital and the surgery center, which is probably an advantage I had in terms of just seeing the other side of what we do that others might not have a direct window into. So it was more, this is an opportunity if you're interested. Actually, true story, I thought I was just going to be a meteorologist.
How did that come to
Random thought. But I was infatuated as a child with tornadoes, and I thought I was going to be a tornado chaser. And my first year in Champaign, I took I forgot the name of the course, Atmospheric Sciences or something. And then I took a second course, and then I realized how much advanced physics you need, and I was done. That knocked me off that track. Yeah,
Physics is.
That was it. I couldn't do it, so I sort of got back on the science pathway at that point.
Well, I definitely don't blame you.
Yeah, it was intense.
So, you did touch upon residency. I was just curious to know if there was any horror stories or something that you think that students should really look out for when they're in their clerkships and then thinking about residencies. What do you think are some very important takeaway messages about what you're looking for?
Yeah, a lot to unpack there. I mean, there's a lot of different considerations for me. I'll kind of tell you how I picked my residency, and then we can kind of go backwards a little bit.
Sure.
So I remember very vividly, I was a student rotating at the St. Joseph program, and I remember a surgical case that I was involved with, and as a student more in an observation type role, but I remember after the case was done, I went up and thanked the attending for letting me participate, and he's like, I'm not the attending, I'm the third year resident, and I was like, wow, you're really competent, your skill was really high, And I was impressed, and he was doing the entire case, basically instructing the junior resident along the way. I'm like, wow, that's the product of the training at this particular program is really high. That's what I want to be. So that kind of sealed the deal for me. In terms of, looking at different programs, I think there's really not a best program for everyone. There's a lot of differences. I mean, there's VA programs which have a much different culture and demographic that you treat compared to non-VA programs. There's large programs and smaller programs. In my program, I actually had 5 residents per year, which was a lot. In hindsight, I probably would have thrived more with 1, 2, or 3 residents a year. But some people like that, bigger group. I mean, for me, I'm never the loudest person in the room. I can easily get overheard by louder personalities. So for me, a smaller program probably would have been a better fit for my personality in hindsight. At the time, I didn't know, but that's something to consider, the size of the program. Each program is very similar in terms of their standards they have to meet per CPME requirements, but each program does offer some unique experiences compared to others. For example, and it's all based on the attendings. I mean, some attendings have a passion for research, others don't. And if your attendings love research and that's what you're into, you're definitely going to get a lot more support at that program compared to others. Some programs are city-based or at a big trauma center where you're going to get more high-energy trauma surgery versus others, right? If you're in New York City, Chicago, Detroit, other major metropolitan areas, you're going to get a lot more of that potentially. And that might not necessarily be true now that I think about it, because some of my busiest trauma places were at Champaign-Urbana, Dixon, Illinois, small towns. So yeah, I mean, I think you have to really understand the teaching methodology at each place is different too. Some teach more in that authoritative role where there's a very defined hierarchy, and others are more collaborative and a little bit more nurturing in a way. So, I mean, that's something that definitely does differ based on the program and based on the culture at that program, which sometimes is hard to figure out until you're there and you're actually observing the teaching in action, whether you're in clinic or in the hospital.
That's really good to hear.
Yeah.
I mean, that's a really great kind of overall picture of what it really does look like when you're there. I was wondering though, knowing what you know now, and post-residency, what kind of skills do you really wish you would have picked up to help you transition into becoming like your own, managing yourself basically as a physician?
Yeah, I think in residency, we're all eager to be in the operating room all the time. And there's a reason it takes a while to develop that skill, and you definitely want to be, you only have one opportunity to train under somebody else's guidance and license. Mm-hmm. You'll be licensed too, but under their guidance. So you really want to get as much opportunity in that domain as possible. And I think what I probably oversaw or didn't appreciate as much at the time was dealing with complications, dealing with perhaps some practice management skills that no one really teaches you until you're actually have to deal with it and you're faced with it. So I think in residency, I probably would have been more eager to participate in a clinical setting and really pushing to follow up or to be involved with the follow-up care of your patients, because that's challenging too. Because in residency, in practice, or at the end of residency, I would say my confidence peaked, right? You're graduated and you feel like you can take on the world. And then when you go into practice, at least for me, I mean, my confidence kind of plummeted from the standpoint that I sort of second guessed a lot of the decisions that I was making, because there's really no one there to back you up, right? If things go south, it's all on you. You don't have somebody to fall back on or co-residents to help pick you up. So it took a while to regain that confidence. So when I say a while, I mean, for me, it was probably a few years until I really didn't overanalyze every decision I made. And I still think a lot about decisions I make, and I'm in my 13th year of practice, but I don't overanalyze and dwell. It's sort of like, I make this analogy before, but it's like a veteran in a sporting event, a veteran quarterback is playing the same game as a rookie quarterback, but for a veteran, it's a much slower game. They've seen defensive patterns many times over again. It's just an easier game to play. It's the same thing when you're in practice. You've seen things before. You know how to handle a lot of different personalities. Your bedside manner can develop because you've dealt with these types of people. So the game just gets easier. I think that, and you sort of know your skill set too. What are you comfortable doing, and what are you uncomfortable doing? Like, so even to this day, like if I have to do, or if somebody comes in and they need, let's say, something like a total ankle replacement, I'm not the best person to do that. I did a couple in residency, but definitely don't want somebody that's dabbling in that once a year, or someone who's doing it monthly, right? And so you sort of know what are your limits, what are you comfortable doing, and what do you need to send out to get help. So I think. Yeah. And
then that's really interesting in the sense because we also know that you have a really great interest in wound care. And I guess in that sense of like, how did that kind of come to be? I know you touched upon it a little bit before,
right.
But then how do your patients actually find you?
Right. So 2 questions there. How did I find myself interested in wound care? It was more of the patient demographic that I think I was gravitated towards. You seeing the impact you can make on that population by giving them hope and by reestablishing some quality of life. I felt that I was making a true impact in that field. I also, in my training, and one of my mentors, Dr. Rodriguez, who you guys are all familiar with too, he was one of my attendings. And we did a lot of limb salvage. We did a lot of Charcot. We did a lot of that type of work in residency. So I felt like I had that skill set to really help my patients in that field as well too. But again, I'll tell you, I really had very little wound care training in residency. We didn't have a whole lot. So a lot of it was taught afterwards. I learned a lot by working in wound centers and working with nurses. Like they taught me a ton. So I think you don't have to necessarily leave residency with every tool that you're going to have in your tool belt throughout practice. You can definitely acquire some along the way too. So for me, again, wound care was more of an organic process, but it's not so much the wounds, but it's really the patients and the impact you can have on those patients' lives that I really gravitated towards. Second part of your question was, remind me? Sorry.
How do you find your patients?
Yeah, how do my patients find me?
I'm so sorry. I was like,
no.
I was so wrapped into what you were saying.
How do my patients find me? So your patients will find you likely through other patients. They're definitely your best referral source, undoubtedly. A lot of my patients come in because other patients told them to come and see you. You can do marketing. Your practice or hospital or wherever you work at will do marketing as well. Reviews do help. It gives you a little credibility. But there's nothing better than someone walking around the community where you work saying how much they appreciated you, your time, your mannerisms, and really the outcome that they were able to achieve with you. So, I mean, that's your best referral source, no doubt. Yeah. And as you see more patients and as your practice evolves, that's just going to be a snowballing effect that just gets, your referral source just gets bigger and bigger and bigger and bigger. So, when people say, oh, you can't practice in Chicago, there's too many people here, I would probably argue that there needs to be a lot of providers here because we've got, with the suburbs, 12, 15 million people that live here, right? Wow. So, we do require a lot of providers to service the population that lives in the Chicagoland area. And if you're good at what you do and you're a good communicator, both with your patients and the other people in the medical community, you're going to be busy. There's no doubt about it. And again, your patients will definitely be your best referral source, no doubt.
Do you feel like, though, because we're in such a large area and there's so many patients to service, do you ever find it that, you get a lot of, second opinion patients?
Not off second opinion.
Yeah, so how a patient sees one podiatrist, right, and get that second opinion, I guess.
Yeah.
Does that happen often because? I was always
In my experience, not often.
Uh-huh.
But I think a second opinion is actually really healthy.
Mm-hmm.
I think when I was earlier on, I took it as like a shot to my ego, but I actually welcome it. And quite honestly, when I'm examining a patient and I'm recommending a treatment, and that's another thing, as you get further along, the confidence you exude when you're interacting with your patients, they will sense that. If you have any hesitancy in your recommendations, they're going to notice, and that's usually when a patient might hesitate and maybe ask for a second opinion. But if I'm not seeing eye to eye with a patient and I can sense that they're really not buying into what I'm trying to tell them, I'll usually recommend a second opinion, and usually they'll come back around to you to do the work, right? Mm-hmm. So, and there's nothing wrong with a second opinion. I think it's actually quite healthy in most circumstances.
That's great.
Yeah.
Very cool.
Yeah.
Kind of switching gears a little bit and talking about like how busy you are and stuff. So a previous speaker we had kind of talked about the discrepancy between billable hours and then how much time she spends like peri-operatively, and how it kind of stopped her from continuing surgery or like doing less surgery. Do you feel like that's something that like you find a discrepancy in? Do you think like certain billable hours are not worth it for like certain procedures, or like how do you kind of manage that?
Mm-hmm. Well, I'll definitely give you my perspective from when I was working in Missouri, because in Chicago, obviously being in academia, it's a little bit different. But what I'll tell you is I don't necessarily pick the patients that need surgery. They pick you, right? So, if a patient requires a surgical procedure, I wouldn't withhold that from them because it's not lucrative enough. Mm-hmm. When it comes to elective surgery, that's where, I guess the decision to proceed with surgery is a little bit different, and every provider is a little bit more or less aggressive in recommending surgery. I'm on the less aggressive side. Usually with elective surgery, I like patients that come to me and almost like beg me, I need this done, right? I have a problem, I have a disability, I have, something that's impacting my quality of life, and then we'll move on to do a surgical procedure. So for me, it's not necessarily deciding when to do surgery or not to do surgery based on how the billable hours are. It's if they need surgery, and that's what we're going to do. Okay. There's more and less efficient ways to do surgery, whether it's hospital-based or surgical center-based. When I worked in Missouri for my elective cases, I had a couple surgery centers we operated at, and that was a lot more efficient. It's a smaller facility, it's quicker, you're in and out. It's usually running on time, so you're not sitting there waiting for your case. So that tended to be a more cost-effective way, I suppose, of doing elective surgery. But yeah, I don't really see it as billable hours as much as if they need surgery, they need surgery.
That makes sense.
Yeah.
I know some people might it just kind of like, she just refers to everyone, whoever's around, basically.
Yeah, she opts to basically not do surgery anymore, just not necessarily because she just saw it was such a investment of time-wise, and not necessarily because of, I guess she was worried more about the finance part of it, because there was that kind of balance, right? But I think that's so interesting that, I guess providers... Surgery, some less. And some
yeah, I suppose you can refer them out if you don't want to operate, but, I think, yeah, go ahead.
What is a billable hour?
A billable hour is likely... So what they're basically stating is that by doing surgery, you're not necessarily getting paid during the time that you're preparing for the surgery. Maybe talking to reps, getting the instrumentation you need, going through x-rays, mapping out what you're doing, surgical plan. You're not getting paid necessarily to drive to the hospital, to scrub in, to wait for your case. You're not necessarily getting paid for afterwards when you're doing the global period for the 90 days where they come in for dressing changes, post-operative care, and things like that. So instead of changing a cast, you could be seeing 2 or 3 other patients that you can bill for, as opposed to someone who falls under your global care. Yeah.
Hello?
Yes. I help.
Can you like describe it then? So as a provider who only does surgeries like every now and again, like you said, like a total ankle replacement maybe once a year or something, or you're not really doing surgeries back to back to back, where those hours can kind of bleed over into one or the other, versus a physician who is just kind of doing like one or two surgeries a week, how that would probably make the difference, where that other provider would be like, oh, I don't really see the benefit, versus another provider who is constantly doing surgery would have a different outcome. Does that make sense?
So is your question, how many of those surgeries do you need to do to expect a good outcome?
Yeah, I suppose, as to where not to see it as like, oh, I'm spending way too much time, whereas I could see a few different patients and do cast removal or this, and this.
Yeah. So I think we might be asking two different questions, but certain procedures have a steeper learning curve than others, and if you're not doing enough of it to climb that learning curve, you might not be the best person to do that procedure. And that would probably be something that I would recommend referring to somebody who's a little bit more experienced or skilled in doing that. Regarding the second question, again, I think it depends on what your goals are and what's important to you, right? And if you're trying to maintain a surgical practice, obviously you have to do surgery, and you can. Surgery for me, elective cases were usually before clinic, so I would oftentimes do it around like 7:30 a.m. and then clinic would start at like 10 a.m. or something like that, which was a nice balance. So I think you really have to prioritize what's important to you and how do you want to curate your own clinic, right? How do you want to create your clinic? Yeah.
Because does that really kind of drive where you want to go to residency and then fellowship right after that?
Yeah, in a way. But what I'll tell you, kind of going back to your question too, based on the complex, and it really depends on your reimbursement model. Because if you work at a hospital versus an orthopedic group versus like a private practice, your reimbursement model is going to be different. So if you're at a hospital, your reimbursement likely is going to have something to do with which is related to your RVUs, which are basically related to the complexity of the surgery you do, which is going to place value on doing more complex work like a total ankle replacement, right? So there's going to be value there compared to doing something less complex like amputating a toe or doing an incision and drainage of an abscess or something, right? So that definitely could play a role in reimbursement, depending on the model of your practice, right? Or your contract, I should say. In terms of your second question, you want to get the best comprehensive training you can, and then let that then dictate later on how you want your practice to be. Because you want to maintain as many opportunities as you can at an early stage. You don't want to ever cut yourself short by thinking that, this is perhaps a more lucrative path, or this is the path that I think I want now, and eliminate some of these other opportunities that could present itself downstream. Yeah, so get the best training you can, and that will open up the most doors possible when that time comes. Yeah, sorry.
I think we have a question in the back. He's been waiting just a second. Yeah, thank you.
Can you guys hear me?
Yes.
Okay, so I think we're touching on like financial literacy in the field itself. So like for the avenue of private practice and stuff, and even when working in a hospital system, how should we approach learning about how the financials of the field work? Because the work itself is extremely critical to be focusing on the medicine and
right.
the patient and everything. But at the end of the day, we have to make money.
Right.
So what's a good balance of that? And then where would we learn that?
Yeah. So that's a great question. And where would you learn that? I mean, there's no course in medical school that teaches you financial literacy to the extent you need. So my best advice is through mentors, right? People that have walked that path before you, people that have obtained the goals that you're looking to obtain. you want to reach out to those people and figure out what path did you take to achieve those goals, and what can I expect along the way, right? So yeah, I mean, even for me, I was probably in my late 20s before I knew anything about financial literacy and personal finance, and what are smart, strategic ways to manage your own personal finances and debt and income and things like that. So I mean, yeah, I learned it probably a lot later than I should have. So I mean, in residency would probably be the right time to start to seek out mentorship to plan for that next stage post-residency on how to be smart with your money at that stage. Because residency is nice, you earn an income, and it's certainly enough to sustain quality of life as a resident. And then when you graduate from residency, then you're going to earn a different salary as a attending, and that's the time really when those financial decisions at that young age can have a significant impact 10, 20, 30 years down the road, right? It's those early dollars that can really have a big impact later on regarding like investments and retirement and things like that really no one teaches you. So I think mentorship is the best way to get it. I actually got most of mine through a podcast.
Which podcast?
Which one? Yeah.
It's called the Money Guy. Kind of a funny name, but it's two financial planners that work out of Nashville, and they're it's very no nonsense. They give a pretty good, realistic approach to what to do with the next dollar that you acquire. So yeah, that's my best advice though, is seek out mentorship from people that have achieved what you're looking to achieve, right?
That's really great advice. Thank you.
Yeah.
Do we still have any more questions in the front?
Yeah, I was just kind of wondering, a lot of people have mentioned working in a hospital versus working in a private practice.
Mm-hmm.
I was curious to hear what is your outlook after residency, because obviously there's pros and cons to both. So what are some considerations to consider after residency, like working in a hospital-based section versus working in private practice?
Yeah, so I worked in a private practice, and now I work in academia, which is not hospital, but there are some similarities in a sense, I suppose. So when you're in private practice, and certainly if you're the employer or a partner of a practice, you have a lot of autonomy to make decisions, right? Regarding your scheduling, right? What days you want to work, what afternoons you want to work, other evenings you think would be best suited for you, Saturday hours. Like when I was, again, in a private practice, it was very easy for me to switch my schedule from being at the primary clinic to working at two different wound centers. It was very easy for me to move to that hospital-based clinic at the endocrinology rheumatology office, because that's really where I wanted to be, in that hospital-based practice. It was really easy. It was basically make a decision and let's get it done, right? There was no committees, subcommittees, and approvals, so that was easy. Being hospital-based or being employed through a hospital and a big multi-specialty or orthopedic group or an academic institution, you're an employee, right? So you're always reporting to somebody, right? Unless you're the CEO and president. But you're reporting to somebody, right? Who's reporting to somebody else. So there's procedures and protocols in place that you have to abide by. You can't make any unilateral decisions without consulting with your team. Your schedule, how many patients you're going to see per hour, a lot of these things might be dictated for you. So you lose some control. And some people are very happy with that because they don't want to deal with the nuances of owning a practice, marketing, hiring, firing, salary, stuff like that, insurance. But there's a lot of benefit to that too, because you don't have to necessarily deal with the bureaucracy of a hospital, the politics of being in an institution compared to being private. So there's pros and cons, and it really depends on where you're working and who you're reporting to, and all the relationships at that facility. But yeah, there's pros and cons, right? And you have to figure out what's most compatible with what you're looking for. What I tell graduating residents that are looking for their first job is, it doesn't have to be your dream job. Hopefully it is, and hopefully it's where you're going to ride off into the sunset at the ripe old age of whatever retirement looks like. But I can tell you, including myself, most of my peers, again from the class of 2008, are not in their first job. I'm in my second, right? I have a lot of my co-residents, graduates of my class are not in their first job, right? So you sort of figure out, is this what you want? Is this what you're looking for? Or are you, or do you want to pivot after a few years of getting some experience, getting some cases, learning about the business of medicine, which what we've been talking a little bit, and at that point, then you can maybe pivot towards something that is more conducive with what you're looking for. And honestly, at that time, you have a little bit more bargaining because you have experience, right? So you're a little bit more marketable maybe at that time, where you can, move towards something that you're looking for at that point. So it's a little bit easier at that point.
Is that a reason why you ended up going into academia, or like why are you here?
Yeah, absolutely. I mean, why I'm here was a matter of timing, a little bit of luck, I think, and what I was looking for. So at the time when I was thinking about a pivot in my professional life was 2014, and professionally I was busy. I was making a good living. We owned a home in St. Louis. My wife had a good job at WashU. My kids were integrating into their schools. So everyone from the outside looking in was probably like, you're crazy. Like, why would you leave this, right? The one thing I was lacking was the ability to have more integration into the residency in St. Louis and being more in that academic role in the residency. So I was kind of missing that. That was kind of the one piece of the puzzle that would have created more fulfillment. So how I landed here was, again, chance in a way. So I was newly appointed to a wound care clinic in Edwardsville, Illinois, and to work in their wound clinic, I had to be trained by their practice, if you will. So it was owned by a company called Excelicare. I think they got bought out by another company called Healogics, but I had to be trained by them in order to work in their facility. The training was in Chicago, right? So I came up to Chicago to get trained. At that time, I saw a lot of other old colleagues from the university, one of which notified me of a vacant faculty position of someone who moved out east to work at Dartmouth. And so they were doing a faculty search. So I was like, that's kind of interesting, tell me a little more about it. So I was learning more about the position. I at that time, my kids were in preschool. So if I'm going to move, this is a lot easier than if they're a little bit more in the public school system. My wife is in public health. I was like, this sounds like the right time to make a move. And it was a leap of faith, quite honestly, because, when we moved at that time in 2014, and a good question that somebody asked me, actually, I think Dr. Evans asked me.
Okay.
He was part of the interview group when I came back here. He's like, Dr. Jaffe, are you running away from something or running towards something? And I'm like, that's a good question, right? And I definitely was not running away. It was definitely running towards what I thought was a little bit more what I was seeking professionally. And I thought that was a great question. But at that time, when we moved to Chicago, first of all, I would never recommend selling and trying to buy a house in 1 week. That was horrible.
Crazy.
And we had a horror story with that. I don't know if you want me to get into that, but that was challenging. So basically, our buyers in St. Louis were from living in Germany, and they moved to St. Louis to work for Nestle Purina, and the international tax documents at the 11th hour were not approved. So our buyers fell through, which means we couldn't buy our home here because it was all contingent about that house selling. So we were living at my in-laws. My wife had no job. We had no home. She was like unemployed, homeless, and with like 2 very small children. It was a rough time in our life. Yeah.
Does she keep reminding you about the
Yeah. So, and it's funny because people are like, you moved back to Chicago because my in-laws are from Chicago. It was definitely not, like, we moved here because I was seeking this opportunity. right? And so, yeah, I mean, it all kind of found its way to work itself out. But that's really how I came here. I wasn't, and that's, most jobs are really through networking and word of mouth, not going to like Indeed.com or different job posting boards. It's really through people in your network, right? So when you finish residency, your attendings and specifically your director are going to have a big impact in helping you expand that network and help you find opportunities. So that's going to play a big role eventually. Yeah.
Topic of academia. Can you talk about kind of what your day-to-day kind of look like a week, so to speak? Like how do you teach, also be head of a department, and also practice?
Yeah, not easily. And the first year was really difficult because everything you create is from scratch. When I came here, for example, they handed me the dermatology course and asked me to completely rewrite the entire course. And so that was kind of daunting. And something that you kind of think is true but is not, is most faculty in academia have formal education in how to teach. So that's not necessarily true. So no one teaches you necessarily how to write syllabi, how to write learning objectives, how to write a curriculum, how to develop a course. Some people have that, but most don't. In fact, Wednesday, I'm actually working with a faculty development leadership committee, and we're putting on a workshop on how to create formative assessments. So there are workshops in academia for people to learn how to do those things in the classroom setting, which is nice. But yeah, I mean, to answer your question, the first year was difficult. The second year got easier, and it got a little bit easier and easier as time moved on. But average week is, I would say I'm 30% clinical. So during any given week, 30% of my time is treating patients, operating room, or responding to patients, prepping for clinic cases, things like that. I would say and this has shifted since I took over the clerkship and residency department office, but I would say I'm 40% administrative, maybe more, depending on the week. What does that equal? 70?
That's 70, yeah.
20% teaching, 20-25% teaching, and then maybe like 5% research on any given week. And again, it's going to shift based on the timing of the year, but that's probably a typical week. But it's important to do two things: delegate and lean on the people that are there to help support you, which can be difficult at first, and say no, right? I think early on I'm by nature a people pleaser. Like I like to do things that can help others, but it can be to your detriment too if you just keep saying yes to everything, and all of a sudden your work's going to start suffering. So I think saying no to certain things and delegating are what's helpful too. Yeah.
Since you wear so many hats, can you tell us how you wear the dad hat and the husband hat?
So that is being time efficient and getting more out of the 24 hours that I had as a 20-year-old. I'm in my 40s now, so I think just being time efficient is really the key. I mean, I probably find that I'm most creative early. I get up really early too, probably 4:45, 5-ish. Mm-hmm. Yeah. And then I, when I get home, I sort of try to turn off work until 9 o'clock when they're winding down. And then if I need to address things, that's when I kind of ramp it back up for a little while. So I'm like, what did I, sometimes we'll reminisce on, being a 26-year-old newlywed, and I'm like, what did we do on a Saturday, from start to finish? And it was probably a lot of reality TV and things that were just, things that you had time to do. I just, so I have less expendable time, I suppose, but it's just being time efficient more than anything. And it's a challenge at times. I mean, there are, last weekend we had a conference downtown, and that's sacrificing time away from family. But you have to, again, that's where you have to balance it and say no to things. I mean, you can be asked to do a lot of different speaking gigs, and eventually you have to be like, no, I can't do that. It's not gonna. I got asked to do a talk at a conference in Wisconsin, and it fell on a time when my daughter had a volleyball in the Dells. I'm like, I can't do it. The speaking.
Yeah. Daughter first.
Right. So, and I think, my kids are getting a little bit older too, which is making it a lot easier. So they're more independent. My oldest is going into high school, and then my youngest is in middle school. So, they're not in diapers and need like full-time attention. So it gets a little bit easier. But yeah, I mean, it's tough. I also have friends that have young children. One of my good friends from Texas, she has a son that's like, I think he's 1, right? So they're still getting up at odd hours, and it's definitely more challenging when they're younger. But as they get older, I mean, it's other stressors. Don't get me wrong. I have a teenage daughter, but the independence is there, and you find yourself regaining a little bit more of that time. Yeah.
I think while we're on the topic, sorry. I guess while we're on the topic, because healthcare, especially like surgery and things of that nature, you're seeing very extreme things like trauma and everything like that. I think in your last 13 years or so of practice post-residency, what was something that you maybe didn't initially know that you wish you had known and kind of preempted? So like in terms of like mental health and stuff like that, because a lot of people right now are talking about burnout, especially like having seen COVID and stuff like that. I was just curious what your view is on that, and like even when we're in residency, because the schedule is so like crazy, how do we navigate that?
Yeah, that's a great question, and definitely one that is at the forefront of a lot of our minds, maybe even coming off the COVID time where I think these problems were probably exacerbated. I think it circles back around to the previous question and carving out time for whatever brings you joy. And for me, I find my day is way more productive, and my mood is enhanced if I get up early, because that's when I exercise, like at 5 a.m. So that's something that helps me throughout the day to maintain balance and to kind of have good energy throughout the day, helps my mood, things like that. So I think whatever that creative outlet or whatever brings you that relaxation is important to carve into. There's always gonna be more work. There's always gonna be more things to do. There's always gonna be more deadlines. So I think just trying to carve out some time each day to do those types of things is important, and try not to let those relationships suffer. I think maintaining friendships outside of medicine is helpful for me. So I have still like good friends that I grew up with that we treat each other like you would like when you're growing up together, and I think those relationships are healthy. Everyone's got those friends where you don't see them for years and then you kind of pick up right where you left off, right? So I think those relationships are always healthy too, to kind of fall back upon when needed. So and lastly, if you have mental health issues, like seek mental health support and try to destigmatize getting the assistance if needed. And I think that's something that hopefully will become easier and easier for some. And I think people are getting better about that in general. Just kind of seeing that as part of healthcare. But I think that's also something to, if it's a problem, address it if you can,
Absolutely. I think in general, on the topic of health, we have to take care of ourselves to basically take care of other people, which is something that I think we lose touch of. Mm-hmm. But tying that into your interest in nutrition, every time you've, we've had a few classes with you where you touched upon nutrition. There's a lot of passion behind that. We're curious if, are you still in like a nutrition certification program, or like what's your take on that?
Yeah, I am part of, at the university level, I'm part of Healthy U, or Health University, which is a committee that's designed to promote wellness. To board certification in not wound care specifically, but a goal has been the American College of Lifestyle Medicine, which it has certain pillars, one of which is nutrition. So, I mean, that's a goal of mine. And, doctors of podiatric medicine can become board certified in that. You just have to acquire enough continuing medical education in that specific domain, and then you have to take, obviously, boards. Mm-hmm. So that definitely is a goal. Haven't achieved that one yet, but definitely something to work towards. But yeah, I mean, I think we've definitely identified that nutrition is generally lacking in medical school curriculum, or curricula is the plural of curriculum, I think.
Fair question.
Yeah.
I don't know.
But so yeah, I think opportunities to be able to integrate that into curriculum is something I try to do. So yeah, it's funny. It's a funny topic because I've given it at the school level, which is not necessarily fair because some students might not be as eager to challenge you, but I've given nutrition lectures at conferences amongst peers, and that's really where I get a real sense that nutrition is polarizing. So when I present evidence that is contrary to people's beliefs and habits, they definitely take it personally. They're like, whoa, I'm just the messenger. I'm just telling you what's out there. But it's I kind of like that, and it really demonstrates that people care about this topic. There is a lot of passion out there, and people are really feel strongly about their beliefs. So it's a fun topic.
Yeah.
Yeah, I enjoy it.
So kind of sticking with nutrition, so you were saying how clearly people care about it, but we don't have enough time in med school, in the curriculum, to have a course. Do you think we should have one as for any healthcare profession, not just DPMs, MD, whatever? Mm-hmm. Do you think everyone should take one?
Yes. I don't know if it would necessarily be called nutrition, but again, maybe lifestyle medicine or preventative medicine or something along those lines where nutrition falls under that specific course learning objectives. I think a lot of nutrition that we learn is more reactive to patients that have underlying health conditions as opposed to being proactive to prevent some of these chronic metabolic health conditions. We learn a lot about vitamin deficiencies, which are so rare, although interestingly, there was a pediatric podiatrist at the conference this weekend that was describing a patient that had scurvy, which I didn't think it was possible to have scurvy anymore in the United States, but I guess it is. Vitamin C is so ubiquitous, I guess. We learned a lot about these diseases, kwashiorkors, and things that really are just so infrequently seen in the United States and really Western populations. So I think more of a focus on preventative care and how to implement that in our practice is something that is important. But in order for that to make its way into the curriculum, I think what has to happen first is a pathway for physicians to get reimbursed for the time spent counseling patients on nutrition and prevention. And they're getting there. There's a lot of strong advocacy groups,
Yeah.
Thank you, that are working with CMS and Medicare and such to get certain codes that providers can submit to get reimbursed for time spent on counseling patients on those. So when there are those pathways to get reimbursed for that, I think it then can kind of trickle its way down into curriculum so that people can gain that skill and be able to get reimbursed for that skill, I suppose. Because right now, I mean, it's difficult. And if you're seeing, a patient every 15 minutes or 20 minutes, you really don't have a whole lot of time to go through their food diaries and their logs and counsel them on, go through food frequency questionnaires. And there's not a whole lot of time for that. Fortunately, we have nutritionists and dietitians and people like that you could work with, but there's not an easy pathway to get your patients under their treatment, quite honestly. So it's difficult. So yeah, it's tough.
I guess to add on to that, because over the summer, I was very fortunate to have research with you and Carol Kurth. And in that study, we ended up discovering that patients are receiving proper, like they are going to see nutritional like counselors, but for the most part, most of them just receive a pamphlet, and they do have discussions with their doctor. But I think the trend that we started to see is like possibly that their patients themselves might not actually be choosing the right choices. Like they're aware that they need to, that what is healthy, what is not healthy, but there's that now like that other element of actually like looking at a nutrition label, how to actually interpret that. Do you think that there's a way in like training physicians that would be like do you see basically a better way of trying to get physicians to help their patients understand nutrition labels, or do you think that that is something that us as podiatrists is something that we should invest more time in doing, or is it something that you think that we should continue passing it off to nutritionists and dietitians?
Yeah, that's a great question. I think first off, it's a strong assumption to assume that doctors know a lot about nutrition too.
Yeah.
So, as evidenced by what you'll see in doctors' lounges serving you for lunch. So, that's kind of the strong assumption that doctors have a good understanding too of nutrition and that education. But, assuming they do, we're guilty of that too. And it's really at Condell, when we get a new patient, we do counsel them on their initial encounter on the importance of nutrition, glycemic control, if that's relevant, and they get a pamphlet, and that's unfortunately the time we have. The first visit, we do give them 2 hours, which is a long visit, probably longer than most clinics, where we do counsel them on all this, but subsequent visits, we really don't have a whole lot of time to reinforce. And to be able to really impact change, you really need to talk to them about nutrition labels, talk to them. In that study too, patients also have a hard time knowing what nutrients are in whole foods, things without a label. So they don't necessarily know like this food is high in fat, this food's high in fiber, this food's, fill in the blank. So that's, something that I know patients struggle with too, but you have to really get granular to going through their shopping list together and like going through meal prep and how to cook certain meals, right? So that's time that's really, really difficult to, to dedicate as a provider. It's difficult. I don't think there's a good pathway right now to educate them, to be honest with you.
No, it's fair. It's always good to hear it. At least, we don't really know what to expect. And I think a lot of us don't fully understand or grasp how difficult it is to properly absorb nutrients.
Yeah, when you look at most algorithms to treat chronic diseases, diabetes, hypertension, heart disease, fill in the blank. If you look at the top of the algorithm, it's almost always going to say changes to lifestyle or lifestyle modifications, and then it goes into all the medical management. And I would argue that almost always that gets overlooked or very, very briefly gets approached, and then we go right into the pharmaceutical and medical management. So more emphasis does need to go into the top of that algorithm, but again, there's probably not a good pathway in our system right now to implement that, which is tough.
Yeah. So we are getting close to the end here, and thank you so much for joining us.
It's my pleasure.
We are dying to know if you could have one song be on repeat in your OR, what would be the song?
I'll tell you what song I wouldn't choose.
Okay, that works too.
And there's a specific reason. Not that I don't like the song, but I was in a case with Dr. Robert Joseph, and it was a longer case. I think we were doing an external fixator on a patient with an equinus deformity following a midfoot amp, and we were kind of gradually correcting it. And for some reason on his iPod or iPhone, it was playing Dave Matthews Satellite for like 2.5 hours. So, true story. And we listened to it over and over and over again, all case. It was crazy. So I would not pick that one.
Okay.
Not that I love Dave Matthews. I saw him last year at Northern Island. I grew up in the 90s. I love Dave, but God, no. Not that one
anymore.
So I don't know if I could pick a song. But if I were to pick like a station on satellite radio, it'd be 90s rock.
Okay.
So maybe like some Eddie Vedder for like 2 hours, or like Foo Fighters.
Yeah.
Green Day.
Yeah.
Stuff like that.
Definitely.
So that would be that. So like I was traumatized by that song on repeat. So I really can't listen to that on repeat. I lived it. I would not wish that upon anyone. But yeah, I would go 90s alternative.
I could see the war flashbacks in your eye.
Yeah, it was. And in hindsight, it's like, how did we not just ask one of the circulators to change the station? But we didn't. I don't know. We just listened to Satellite over and over and over again.
I sense some PTSD.
A little bit. That was a very triggering question.
I'm not sure if the first year students know, but Dr. Jaffe does play guitar.
Yep.
And he's very, very talented. And sometimes he'll post on Instagram. So I always assumed that music is part of your life. To some degree. So.
Yeah, I wish I had more time to do it. Last year, got to live out one of my dreams, playing live at Dance for Diabetes, which was amazing.
We were so sad not to see you there this year.
With Dr. Dookie on vocals.
Yeah.
For those who don't know, she's a former professional singer in the Philippines, which is amazing. So yeah, that was amazing. And performing, I don't know if anyone ever performed in a band. That was my first time with others. They very much hide your imperfections on playing, which was amazing. Because everything I post, I play alone on an acoustic guitar where there's really no ability to hide anything. So that was amazing, having a drummer and other guitarists and some vocalists to hide and drown out your imperfections.
I guess I never really thought about that.
Yeah.
That's good to know.
That was amazing.
Alrighty, well, thank you so much for coming out today and for speaking with us.
It was my pleasure. Thanks for inviting me.
Yeah.
Yeah, thank you guys.
Thank you.